Thank you very much for attending this webinar. My name is David and I'm a bioinformatician at Karolinska Institutet. I'm also a bioinformatician on a Swedish node for the Nordic Information for Action eScience Center. And today I'm going to present the summary of activities of this consortium, which is abbreviated as the NIASC. So NIASC is a 5-year project. It's funded by a Nordic Council of Ministers, and its main goal is to develop eScience tools that will enable us to perform a risk-stratified cancer screening in the national cancer screening programs. And by the end of the program, we aim to have at least one algorithm integrated in at least one national cancer screening program. So we are going to achieve this by promoting open access to the biobank samples and the biomedical data. We are planning to improve the information and communication technology for collecting biomedical data and informed consent, such as mobile applications, for example. We want to increase the understanding of the ethical challenges related to the big biomedical data. And we want to also advance generic eScience tools for analyzing molecular and the genomic data and text mining, etc. And then this will be optimized for risk stratified cancer screening. So NIASC perceives that to achieve these goals, the Nordic concerted effort is necessary, and the Nordic countries should share knowledge and expertise and develop a common tool which would be adaptable to the Nordic infrastructures. But also we aim to export this developed tool to the other countries as well. The roadmap of achieving the NIASC goals is the following. We have a Nordic population at risk at cancer. Then we have a population-based biobank samples and the outcome registers. By the unique personal identification numbers, we can link these data sources to omics analysis and then feed to the eScience tools and then develop a risk predictive algorithms and then integrate to the national cancer screening programs, which will tailor to the for the individual risk. And as the outcome, it will be a better use of resources and the better health of the Nordic population. Right now we have a different spectrum of projects, starting from the national biobank softwares, computational methods for cancer susceptibility, machine learning, text mining, IT tools for risk stratified screening, as well as mobile applications such as mobile games to nudge people to attend, to increase attendance on the screening programs. One of the specific programs are open source IT systems for handling Nordic Big Biomedical data, where we are trying to develop a scalable infrastructure for storing, analyzing, and sharing big biomedical data across Nordic countries. To achieve these goals, to succeed this project, last year we organized a workshop on the best practices for handling big biomedical data, where we invited the infrastructure providers and national representatives from the national biobanks from the Nordic countries, where we formulated the joint IT needs for the Nordic biobanks. We also found a group which will be optimizing and developing a bioinformatics software for analyzing the genomic data, and as well as to develop a software and a framework where it will enable to perform a registromics, which is basically a reverse data mining. And now in 2016 we are planning a bigger workshop where we will follow the developments from the last year, and there was also the plan of the future activities. We are developing open source IT tools to enable the risk-stratified cancer screening, and one of the first steps is to develop an open source invitation software, which will be adaptable to any Nordic country in any cancer setting or any national cancer screening program, but it will be also could be adaptable to other countries as well. And we have some ongoing use cases right now. We are also promoting to have a open data, to have open access to the databases and to show on the web what data is available. And one of them development is the NordScreen. NordScreen is basically a modification of the NordGAN, which is NordGAN displays important cancer data from the Nordic countries, and the NordScreen we will display important data available about the screening programs in the Nordic countries. And for the first version, we will display cervical cancer. We will from Sweden and for Finland. But for the next steps, we are also planning to include other Nordic countries as well. One of the main challenges in the bioinformatics is ever-increasing volumes of the genomic data, and the scalable bioinformatics softwares are missing. So we have parallelized NCBI BLAST, which is one of the commonly used bioinformatics tools, and we have been collaborating with our Polish partners in the Polish grid infrastructure, where they modified NCBI BLAST to be adaptable to their infrastructure, and the developed tool, which we call PCG BLAST, is now 10 times faster on the Polish grid infrastructure compared to the NCBI BLAST. And this will be also available as open source as soon as it is accepted for publication. We have also the external collaborators. One of them is the Icelandic National Cervical Screening Program, and we are receiving all the Icelandic samples in the coordinating office at Karolinska Institute. We analyze the data and send back to Iceland. We are quite actively collaborating with IARC and the Nordic Cancer Union to develop a NordScreen project, which I mentioned in the previous slide. We are also providing some tools, and we have been participating in the Pan-European project, EGI Engage. We are providing bioinformatics tools and expertise as well. And first use case was the tools for the viral metagenomics. Now we have also applied to deposit the data in the EU DAT. Also, we are collaborating with the National Cancer Institute to develop a mobile application for risk-stratified cancer screening and the gathering, collecting the informed consent. NIASC is actively participating in the B3 Africa, which is a European project that bridges European and African countries. So the European countries will provide the expertise and infrastructure for African countries to develop a biobanking infrastructure. So the NIASC as a consortium has key performance indicators where we measure our success. One of the most important indicator is number of risk stratified strategies integrated in the national cancer screening programs. This is one of the main goals of the NIASC. So right now we have 2 such projects under development. We have developed about 13 open source eScience tools. Well, the two is already developed and 11 is under the development. And we also measure as well also as how many projects we have, where we have at least more than 3 Nordic countries participating. At the moment we have 4 such projects ongoing, And also we have quite a lot of academic outputs, such as workshops and publications. 8 of them is already published, or the workshops are organized, and 42 right now is under the development or the process to be finalized. Thank you very much, and if there is any questions. All right, one of the questions was about the PSG BLAST, and it was if it's an alignment tool. Yes, the answer is it is an alignment tool. It's basically a modification of the NCBI BLAST, which performs a pairwise alignment. Right now we have already integrated the nucleotide BLAST, which aligns 2 nucleotide sequences together. And if it will be the bigger demand, we can also expand.
Hi, and welcome to the second part of the seminar today. My name is Miriam Elfström, and I work as a postdoc in the Department of Laboratory Medicine here at the Karolinska Institute. And I also work as a process leader for cancer prevention at the Regional Cancer Center of Stockholm, Gotland. And today I'll be talking about risk-stratified cervical cancer screening to reach non-attending women. This is a NIASC project. Now, to give a little bit of context on why this is important and what we know so far, I thought I would describe first that more than half of all cervical cancers in Sweden, that's 64%, arise in women who have not attended screening. We also know that switching to HPV-based screening allows for self-sampling in a way that wasn't possible with cytology-based screening. It is more convenient, and studies have shown even an increase in screening attendance. A recent meta-analysis has shown a doubling of participation among women who do not routinely attend cervical screening when offered self-sampling. And a Swedish study has shown that 17% of cervical cancer cases here in Sweden could be avoided if we systematically implemented self-sampling for non-attenders in our program. The method is simple and safe, but the response may differ between populations, and real-life experience is still needed regarding quality assurance of testing and ensuring that HPV-positive women attend further follow-up. There are a couple of challenges with this type of project. There's a lack of IT support or only commercial IT systems available, which makes the costs somewhat prohibitive in certain circumstances. There are also commercial or expensive self-sampling devices primarily on the market. And so with that in mind, we intended to create a new type of project and look at the logistics and self-sampling and acceptance of self-sampling, specifically among non-attenders to cervical screening when offered the chance to order a self-sampling kit online. A little bit about the target population. Women who do not attend screening are sent annual renewed invitations until they attend within the program. So for this pilot study, women who had not attended screening for at least 10 years and had been sent then at least 10 renewed invitations were identified. And what this looks like then is for women 33 to 50, about 3.4% of the population here, and for women 51 to 60, about 5%. This is a high-risk group that needs to be targeted for specially designed screening efforts. So to identify this population, we looked for women 33 to 60 with no test on record for the past 10 years, women that had been sent a reminder invitation for 10 years in a row. And of those, we selected 8,000 women for this pilot study, and we randomized them to a study letter with a self-sampling kit directly sent to the woman, and this was 2,000 women, or a study letter with instructions on how to order a self-sampling kit, also 2,000 women. And then in this third study arm, we sent women a letter with an invitation to call the coordinating midwife. And here women could call during phone times and ask questions, discuss any concerns they may have about screening, request a renewed invitation so that they could attend regular screening, or they could request a self-sampling kit. And in the final arm, in the fourth arm, we invited women in the routine fashion. So we sent a renewed invitation to 2,000 women, and this encouraged them then to attend regular screening and appointment. And the first two study arms, the kit, once completed, was sent to the Cervical Cancer Prevention Center, and HPV testing was carried out by LabMed. Those women that were high-risk HPV positive were referred to the gynecologist for further follow-up, and those that were negative are referred to the next round of routine screening. And then in the fourth arm, routine procedures were used, and follow-up was based on routine protocol of results. And then a little bit about how the data flow then. This is possible because we can, at this organized screening program office, receive information on all resident women in Stockholm from the population register and link that then to cytology laboratory information, so information on all smears carried out in the greater Stockholm area. And this includes the date that the smear was made as well as the results. And this allows us then to identify these women ages 33 to 60 that had no test on record for the past 10 years and select them for the study. We used the COBAS PCR female swab sample packet, which is shown in the picture there on the upper right-hand corner. And the sensitivity for this, for HPV and urine and vaginal samples, has been found to be high and comparable with cervical samples. This kit is used for large-scale HPV surveillance in Sweden, and the price is quite low. It's just 5 Swedish krona per kit, or 55 cents. We also developed instructions to minimize the dependence on text, and you can see those on the left-hand side of the picture. There's a process for preparation, for the sample taking itself, and then how to send in the kit so that we can analyze it. And this is how the online ordering application for the self-sampling kits looks. As I said, the women received a website link, and they also received a code in their invitation letter. And this code they entered into the first field of this online application, and then it populates with their information on their name and their address, and gives them a chance to double check that, as well as enter contact information. And this is an open source application in line with NIASC, the NIASC project. The outcomes that we will measure are logistics and communication, how this is implemented in the context of the organized screening program. And then we will also look at participation by study arm, the number of kits ordered and the number of kits returned. As a side, women may attend routine screening after receiving the kit, so we will capture that in the registry and consider that attendance as well. We will look at acceptance of self-sampling and reasons for non-attendance to better understand this population of women, and we'll look at the phone calls to the coordinating midwife to understand this better. And then finally, we will look at the clinical follow-up of HPV positive women, to ensure that we are capturing them and that they are attending the follow-up. And finally, the long-term plan is that we will scale up the most successful method, which we will determine through the analysis and evaluation of this pilot program. So with that brief overview of our work within self-sampling, I would like to thank you for your attention and invite any questions. Perhaps in the meantime, I can go through the polls that were listed. The first question is cervical screening organized in your country? And based on this, the attendance in this call, 81% say that yes, it is organized in their country, and 18% say no. And then when we look closer at that, we can see that organization let's take up this second pod. We can see that there are different responses to what is meant by organized screening. The majority of respondents, those of you that are on this call, have said that personal invitations is a key factor in whether or not it's organized, 92.8%. And then also that there's a screening registry that monitors quality and effect of the activities. And these aspects, I think, are quite critical to being able to track both the process of screening as well as the effect that it has. And personal invitations are known to motivate attendance greater than mass messaging for attendance. And within personal invitations, another critical factor is that the program provides appointments for testing to the population. 64% said that that was a key aspect. And I would agree here. I think providing a time and a place individually to each woman encourages participation and makes it clear how the woman should go about getting screened. So thank you for participating in those. These are key points, and there is some differences. And what we know is that out in Europe there are differences between programs based on historically how they've been built up, and resources, and organization of healthcare in general. And now on to some of the questions that have been written in. The first question is, what do you know about the women not attending regular screening? Is it likely they will order tests online? What we know is that the routine annual reminders haven't worked so far, that this is a different group of women, and that perhaps by offering something that they can do in the home and that they can own themselves, that they can go in and order themselves, that this will encourage participation. In other studies of self-sampling, self-sampling has been directly sent to women, or women have been able to call in and order a kit. And so we're hoping that by investigating this ordering of kits online, we can have some clear ideas of what people respond to the most. The next question is, how does it look like the routine invitation in Stockholm? And the routine invitation says that it's an invitation to screening. It gives a time and a place for the screening appointment, and also says that the screening appointment is free of charge. At the bottom of the invitation is some extra information on why cervical screening is important, and where to go online to get more information. And information is provided in several different languages on the healthcare website. And then finally, there's a question of whether this approach is reaching the segment of the population that are too busy to screen or to go into a clinic. And this may be the case. It may be easier to fit in self-sampling at a moment in the evening or on the weekend, but we will wait and see whether or not this seems to be the case based on the phone calls that we received and also the number of people participating. So we will have more results on exactly motivations to self-screen as well as for having not participated previously when we look more closely at our data. So stay tuned, more results to follow. Thank you again. Bye-bye.